Okay, everyone, this is going to be my second attempt now to try to upload this video for you and try to give you a little lecture. The other one was 40 minutes. This one will probably be about another 40 minutes as well. I want to talk about a couple of different things. First, a little bit of reminders. Number one, we have the group presentation that is due next week on week 9. And so I want to make this very clear. Everyone must work together as an adult to create this PowerPoint presentation. If you cannot act appropriately and help your other students, I do not want to get any emails or anything from students telling me that you do not participate in this. This is a group project. Everyone must work together. Please, if you are doing your group assignment, please help out and equally do your part as necessary for this assignment. I'm grading everyone as a group, okay? I'm not grading people individually because this is a group project. It's very hard for me to do that, okay? So I do apologize for those that have had some problems with some other students, but I want to make it very clear. If you are not helping out your other students, I will know about it, but I do not want to have to address it. I hope this is resolved by week 9. If I have to deal with something in week 9, we will go from there, and there will be consequences to your grade due to your failure to participate in the group project. With that being said, I hope everything is understood now. We did miss class on Tuesday, which was sad. I saw some people that did come, and I know some other people that weren't able to come. So what I wanted to do on Tuesday was to talk about our chapter 12 and chapter 13. Well, what I'm going to do, I'm going to hurry up and talk about chapter 12 and chapter 13. So while I am plugging in my computer real quick, how about you get chapter 12 pulled up, and we're going to go from there. So I'll give you a few minutes. Pull up chapter 12 PowerPoint via Blackboard, and then also have ready chapter 13 because I'm going to go from 12 all the way to 13. So I'll give you a minute to do that. Okay, much better. My computer from the first attempt did apparently ran out most of my battery. So I'm going to start with chapter 12. We're going to talk about the reproductive system. I'm going to start with slide number 2. So if you're following along on your computer, go to slide number 2 and we're going to talk about that. When we talk about STDs, STDs are commonly referred to as venereal diseases. We also refer to these as STI. Sexually transmitted infections, because for the most part these are infectious processes that happen that we know are spread by sexual contact. They are usually transmitted through body fluids such as blood, semen, and vaginal secretions as well. Most spread with direct contact to infected skin in the mucosal membranes of the vagina, anal cavity, and the oral cavity. Most are treatable for the most part. There are no treatable ones such as HIV and herpes simplex virus. Something that's really interesting now on slide 4, 1 in 4 teenagers will get STDs or STIs. The STD rates in the U.S. pretty significant. Syphilis is rising, which we were not seeing so much before, but we are. If you were to go to a community health department, which you can get free health screenings, there are 4 STDs that are reported. There's actually more than that, but chlamydia, gonorrhea, syphilis, hepatitis B, and of course HIV. So it says 4 STDs, but actually it's HIV as well. It has to be reported to the government, and they do keep track of that. When we talk about safe sex practices, how I said 1 in 4 teenagers will usually get an STD or an STI. Safe sex practices have been in question a lot. So we try to wonder if it's the younger people that are doing it, or is it the older people that are doing it. So take your side and take a minute and kind of ask yourself, who is doing that? Is it the younger people or the older people? Well, it's actually younger people that are having the safer sex practices. It's the older people that are not. We contribute that a lot due to the education. You see, nowadays there's a lot of education about safe sex, abstinence programs that they teach in high school. I didn't get so much when I went to high school and even in middle school. And so it's the elder population that is doing the not so safe sex practices versus the younger crowds. Despite that, 1 in 4 teenagers will get an STD. Now, when they get an STD, most of these are treatable, though. We're talking about the um, prevalence of HIV infections and herpes and so forth like that. Moving on, slide 5, chlamydia and gonorrhea, they go together, the same thing. Chlamydia is one of the most frequently reported infectious diseases. With chlamydia, with females, it can lead to pelvic inflammatory disease. 75% of the men do not have symptoms, kind of like gonorrhea. The same thing with gonorrhea. 50% of the males are asymptomatic with gonorrhea. With signs and symptoms of this, females have thick vaginal discharge with burning sensations. They have itching, abdominal pain, and also painful intercourse. Now, with men, they also will have a pretty apparent discharge from the penis. It could be in very different colors. It's fluid-like substance discharged, burning sensation as well as itching. They also have burning when urinating in a swollen scrotum. Now, we try to rule out with these patients whether or not that they are having a urinary tract infection, but it's pretty easy for us to kind of determine that when we do. To determine whether they're having STD or not, we do diagnosis. If you go on the next presentation of slide 8, we usually do swab cultures, we do grams, stains. We can also do a blood test to see what they have. The one thing that we will do for as far as treatment of this, gonorrhea or chlamydia, we will give antibiotics to both partners and follow-up testing is required. So you go to the next slide, 9 is the same thing, is basically chlamydia. Gonorrhea and chlamydia, they go hand in hand. It's whether, what the swab shows, whether it's gonorrhea or chlamydia to go with it, depending on the bacteria that they have. Moving on to slide 10, genital herpes is called herpes simplex 2. It's because you have 2 sexual organs, and so the way I remember herpes simplex 1, which is the cold sore, herpes simplex 2 is a different one. It's the sexually transmitted one because you do have 2 sex organs. Usually genital herpes, there's ulcers that basically ooze, and when they come in contact with other skin, they transmit it directly that way. If you think of cold sores on someone's lip, that's basically what they have in their sexual organs. With herpes simplex 2, it's a virus. We can't really treat it. The only thing that we can do is give antiviral medications to kind of decrease its outbreaks and so forth. A lot of these people have recurrent infections that come and go, and then it goes away. So that's how we basically treat it and so forth. On slide number 12, we know 1 in 6 adults carries the highly contagious virus herpes simplex 2. With that being said, if you have herpes simplex virus 2, you're at risk of developing HIV because of the lesions, and if you were to have sex during the lesions. Something to note too is someone can get herpes simplex 2 virus to having oral or genital sex that way as well. So you can have possibly herpes simplex 2 around your face and mistake it for herpes simplex 1 when it was in true cause to be the herpes simplex 2. I'm going to move all the way on to slide number 19 now. I'm going to talk about benign prostatic hypertrophy, which is BPH. With BPH, if you kind of scroll to slide number 20, and then I'll talk about it. So if you look at slide number 20, what BPH is this benign, non-inflammatory enlargement of the prostate gland right there. With that being said, then enlargement of the prostate gland, you have the urinary bladder, which is the top of that prostate gland right there. Then you have your urinary tract. What happens with that enlargement of the prostate, it causes people to have different urination patterns, sometimes very difficult urination, fullness in their bladder, even after they go to the bathroom. And so it's really uncomfortable for men that have it. Um, Moving onward, if you want to still look at that picture, what we know is the cause, really we really don't know what happens. It's just a non-inflammatory things. Some medications can cause it, believe it or not. We diagnose this with a H&P. We also do a cystoscopy, which we actually go through the urethra and actually diagnose it that way. We can also do a CAT scan too. The treatment that we want to do is give drugs such as Flomax. I'm pretty sure a lot of people have seen the commercials for Flomax. We also do beta blockers. We can do some radiation to the area to try to shrink it and so forth. Sometimes it works and sometimes it doesn't. Moving on, I wanted to hit... what's the big thing? Endometriosis, I'm not going to talk about. Pelvic inflammatory disease, I'm not going to talk about. I moved all the way to slide number 40 now. Talk about toxic shock syndrome. If you look at any of the Tampax boxes, and you see that toxic shock syndrome is a big warning. They do that nowadays. It's a huge warning. So they do toxic shock syndrome. And so with toxic shock syndrome, you have these... what the background of toxic shock syndrome is that females were leaving tampons in longer than they should have, such as leaving it in and going to bed, and then what happens as a result of that, it develops a massive systemic sepsis, basically. And so you have these females that were not taking good care of themselves, and they develop shock because of it. So they had initially presented with low-grade fevers, chills, basically something like influenza. They were not feeling well. And then progressively it got worse. Their blood pressure dropped, and they did not do really well at all. And so there was a big scare back in, I want to say, the 80s, 90s, about people and women wearing especially tampons. And so you see commercials nowadays such as Kotex, how they're trying to change the stigma about wearing these tampons and so forth. And for the most part, a lot of people do know the signs and symptoms now. They do recognize it. There's more awareness and everything like that. So on a good note, we are not seeing a lot of people have toxic shock syndrome. Someone can also have toxic shock syndrome without having a direct cause of the reproductive system. But just keep that in mind. Moving back onto what we were talking about, most of the time it's caused by people that have their tampons in place and so forth. So that you kind of know a little bit overview of that. Toxic shock syndrome is pretty interesting, but we really don't see it too much anymore. Moving on, I was just going to talk about slide number 50. Cervical cancer is a big thing. It's mostly a squamous cell carcinoma. There's different types of squamous cells, or different types of cells in the body, as you know. It's a squamous cell carcinoma, so it's that little weird one that has that little eye. So it's kind of associated with that. There's two main symptoms. People that have bloody vaginal discharge, foul smelling is the big thing that we see. Bleeding between menstrual periods after intercourse, and they have abnormal pap smear. We know the biggest risk factor for this is if they have the human papillomavirus, HPV. What we see is most of the time we're giving HPV vaccinations to females and with males as well. And so we want to give the HPV vaccination to these females before they are sexually active. So if you have any teenagers and you have been offered the HPV vaccination, what I would do is take it, because HPV DNA is detected in more than 90% of people that have this kind of cancer. So make sure that you do get the HPV vaccination. So it is pretty much preventable, but you want to definitely get the HPV vaccination. Now, ovarian cancer accounts for more deaths than any other gynecological cancer, ovarian cancer, pelvic cancer, kind of the same thing. It's due to the location of the ovaries deep in the pelvis, which basically becomes inflamed, and you have all the disease process that metastasizes through there. Most of these patients are pretty asymptomatic, and usually they're between 40 and 60 years of age. They're usually taking fertility drugs, or if they are taking fertility drugs, if they have hormone replacement therapy, which, think about it, they would be having that too, if they have a late menopause too. So with that, cervical cancer is really hard to diagnose. I was going to share a story with you about a patient that I had flown when I was doing fixed wing that had pelvic cancer and so forth, but due to the time constraints, I'm not going to go into that at this point. Moving on to slide number 55, we're going to talk about ectopic pregnancies. Ectopic pregnancies are a true medical emergency for one, and it's pretty significant when we think about it. I don't know if anyone has had an ectopic pregnancy before, or if you heard of an ectopic pregnancy, but it is truly very significant when we think of ectopic pregnancies. For me, we will get called if I work on an ambulance to someone that is having severe abdominal pain. It's usually lower, not upper, but it's usually lower severe abdominal pain, and they have vaginal bleeding with pain. What happens with the fertilized ovum, it basically gets implanted somewhere outside the uterus. So if you look at slide number 56, is what I have on my right in front of me right now. If you look at slide number 56, it has all different, the ovum can be implanted in different things outside of the fallopian tube. So that can cause an ectopic pregnancies where it's growing outside of it. For the most part, what these turn into is usually an abortion. It usually is a spontaneous abortion, and how we treat this, we have to basically go in there and clean everything out and hope for the best. Ectopic pregnancies are not something that is survivable, and if this ectopic pregnancy, if it actually ruptures, there's massive blood loss, and you can go into shock and die from it. So we talk about premature labor, which is slide number 57. Premature labor occurs usually in, depending on which book you read. I've read many different books. Some say 36 weeks, some say 37 weeks, some say 38 weeks. Depends on which book you read, but what we're going to say for our purposes is between 37th or the 38th week of gestation. So premature labor, why is it a concern? Well, the really concern of it is that that fetus has not fully had the time to develop like it should. So let's say, for example, that someone has a kid at 32 weeks. So they have a kid at 32 weeks. They're discharged home, and they come to the hospital, again, because the baby's having problems. And they come to the hospital about 2 weeks later. So the kid was 32 weeks. Now they're 2 weeks after that. So add those up, they're 34 weeks. They're still premature. Even though that it is a viable birth, that kid is still 34 weeks. So what we have to do is treat that kid like they were 34 weeks. It's not going to be until 6 weeks after that birth that they will fully be of development, ready for birth. So when someone is premature, we have to look at what the baby's age was and what their date was and so forth, and then go from there. Moving on to the next slide of 59, we're talking about two different things: abruptio placenta and placenta previa. Easy to get confused and easy to remember, though, on the other hand. So abruption. When I think of abruption, I think of something that is bursting, that it basically came to an abrupt stop. And so abruption is a detachment of the normally positioned placenta, and it comes off. And so with that being said, someone will have a sudden onset of severe abdominal pain, so we have to rule out ectopic pregnancy, but we usually will see a significant hemorrhage. If you go to slide number 60, you see the abruption of the placenta from the wall, and basically it came off, and then you have the bleeding. Now moving on to slide number 61, you have placenta previa. Placenta previa is where the placenta comes before everything else. So the placenta usually should come last, but placenta basically becomes before everyone else, and it blocks the internal cervical OS right there. With placenta previa, painless bleeding. So use that placenta previa, painless, bright red bleeding is what you would see with placenta previa. If you look at slide number 62, it kind of would talk about that as well. Okay, for as far as chapter 12, I kind of highlighted everything that I wanted to talk about. If you do not mind, switch over to chapter 13, which would be the neurological disease and conditions. This one's a little bit lengthier, but I'm going to talk about some things and try to hit the major things which I wanted to cover, what I really wanted to cover on Tuesday. I'm going to go through an overview. So I'll give you a minute. Hopefully you have chapter 13 up. So when we talk about the neurological system, it is fascinating. It's one of my, besides cardiology and respiratory and so forth, as you know, I actually like the neurological system. Neurological system is very smart. With the neurological system, we have the central nervous system and we have the peripheral nervous system. The central nervous system comprises of our brain and spinal cord. So that's really important to know. Our peripheral nervous system is everything outside of that. So we have our central nervous system, the brain and spinal cord. Then you have your peripheral nervous system, which is everything after that. We have afferent and we have efferent ways. So afferent sends messages to the actual brain and spinal cord, and then efferent carries those messages from the brain and spinal cord to tell it to do something. We have the medulla oblongata that contains a lot of the critical centers that controls our heart rate, our blood pressure, respirations. If someone was to get hit in the back of the head with that medulla oblongata is located at, they can suffer a lot of different problems. So we have to be really significant of that as well. So if you're kind of caught up now, let's kind of go to slide number 5. That's what I have. We're talking about some vascular disorders, and the vascular disorder that is the most common thing that we see is a stroke. So with that being said, people that have strokes is pretty significant. A stroke is the same thing as basically someone having a acute myocardial infarction or that heart attack. The signs and symptoms that we see with people that have strokes are headache. We have aphasia, they have trouble speaking, they have trouble articulating their words, they have trouble remembering things, they have facial drooping, their face is going to be drooped on one side. It is a big significant thing. They have like a lot of facial drooping depending on which side of it is. You have control of one side of the body, lost control of the other side of the body. Interesting thing. The right side of my head controls the left side of my body. The left side of my head controls the right side of my body. So if someone is having trouble on their right-hand side, I'm going to think that the stroke is on the left side of the brain. If they're having trouble on the left side of the brain, they're going to have a stroke on the right side of the brain. That makes sense a little bit? Probably does. A little bit of review for everything else. So for the most part, they're going to have these signs and symptoms of being really disoriented. Someone that is truly having a stroke may even appear that they're drunk. That's why when we have people that are drunk, we kind of look out and try to rule out that they're having a stroke, try to rule out they're having a sugar problem, and then from there we can kind of say, hey, they're drunk. Have I seen someone that was drunk and having a stroke? Not yet, but you never know. So with that being said, I covered a lot of the signs and symptoms of it, and now we're kind of going to talk about the etiology. It can result from a couple different things. It can be a clot in the brain, it can be a hemorrhage, so their blood vessel ruptures, or it can actually be a cerebral embolism where there's a fat blockage that's there. The most common cause of this is caused by uncontrolled hypertension. People that have high fat diet, smoking, and family history also is really significant of it. So when I talk about stroke, I want to give you kind of a timeline about strokes. And so say for example, you are having a massive headache, your face you notice is starting to droop, and your vision's kind of a little funny, and things are just not acting right. So you kind of take 10 minutes or so and kind of figure something out. Like, I need help. So you wait 10 minutes and call 911. So we call 911 and it takes them about 10 minutes to get there. So the paramedics get there and they say, "You know what? You're having a stroke. We need to get you to the closest stroke center." Good. So they take you to the closest stroke center, and so they're there for 10 minutes. So now we're at about 30 minutes into this. So you have a stroke, and you're having stroke-like symptoms, and so the paramedics take you to the hospital. It takes another 10 minutes. So now we're at 40 minutes. You get to the hospital, what's the first thing that they do? Nope, it's not getting checked out by a nurse. It's being registered. The hospital's got to get some payment. They got to figure out how they want to treat you, but they want to get your payment first before anything else changes. They want to get you billed already. So they start that payment log so that you get registered. Then you have a nurse that comes. So we're about 50 minutes into it. Nurse comes and takes your vital signs and so forth of that. So you have the nurse that takes your vital signs. So then you have a doctor. You gotta have a doctor to come see you, right? So doctor comes sees you. Said, "Oh, I think you're having a stroke." They do a little test. They do a lot of significant tests. It takes about 15 minutes actually to do a full neurological assessment. But this doctor's pretty quick, and he gets it done in about an hour. Excuse me, about 10 minutes. So now we're at that hour. Within that hour, you have to have a CAT scan done, and it has to be interpreted. So they need to get that back within an hour. So now we're at 2 hours. Good. We've done pretty quick. So this has been going on for 2 hours. But we need to make a decision at this point. Do we give clot therapy or not? Well, it depends on what kind of stroke you're having. If you're having a hemorrhage, then we can't give you any clot busters. If we don't see a hemorrhage in your CAT scan, then we can decide to give you this highly clot buster drug that is very potent. It's called TPA, and so we can give TPA to you, and which is very controversial, and we see a lot. It's especially what we're doing. We're flying a lot of these patients that have had with stroke-like symptoms, and they're giving TPA. So we have to give that TPA within 3 hours, is what they're saying. The new guidelines have came back and said TPA can be administered up to 4 to 4.5 hours. However, that is not approved by the FDA, and it is an off-label use and is still under a lot of different trials right now. So if you're having a stroke, that's a thrombolytic stroke, we only have 3 hours to treat it. If we wait longer than 3 hours, say you had a headache for 3 hours and then you started to notice some weakness to the body, you're still past that limit. The only thing that we can do is what we're doing now is we're taking patients that have had strokes, we're taking them from a facility in the middle of the state of Michigan and flying them to, of course, Henry Ford Hospital or any of the St. John facilities such as St. John, Maine, Providence Novi, and Providence Southfield. That's where we're taking it, where they can go procedures that will remove the clot from the brain and will do different stents and so forth. Neurological care today has become pretty significant, just along with cardiovascular care, but it's actually gone pretty good. Now, let's say afterwards, I'm now on slide number 11, after you have your stroke and you're past that limit, the only thing we can do is supportive care. It kind of stinks. We cannot replace any of the brain cells that were died because of lack of oxygen or anoxic brain injury. So with that being said, I'm going to go to slide number 16 if you're following. We're talking about TIA. TIA is really interesting when you think about it. The way I think of TIAs is, so when we talk about CVAs, I refer to them CVAs as the heart attack of the brain. So acute myocardial infarction of the brain. When you think of TIAs, think of think of angina just in the brain. So what the TIA is a temporary blockage of either fat embolism or either a blood embolism, a clot, that basically kind of temporarily blocks blood flow to a certain part of the area. With that being said, the patients have the same signs and symptoms as someone that's having a regular stroke, believe it or not. So they have the headache, they have the facial droop, they have the trouble speaking, the trouble walking, everything like that. The only way that we can determine whether it is a TIA versus a stroke is if the symptoms come back. And so if the symptoms resolve themselves and they go away and everything's fine, then we can say it's a TIA. And usually within 24 hours of time, people will have a decrease of symptoms. So then we can diagnose it as a TIA. And they're lucky at that point. Now, what happens is people that have had histories of TIAs will have, say I've had like 3 TIAs. Well, what do you think is going to happen when I have that 4th one? Do you think I'm going to go to the hospital, get anything done with it? No, and so people will ignore it, and then it gets worse, and then it gets worse and worse until you never know that last TIA is actually going to be something that's significant, that's going to be an actual stroke. So anytime someone has a TIA, we really, really have to be careful with these patients. So moving on, we're going to go to slide number 20. I'm going to talk about epidural and subdural hematomas. There's a lot more. You can also have a subarachnoid bleed as well, but I'm not going to talk about that for this purpose. Talk about the 2 most common. So when we talk about epidural hematomas are a collection of blood that forms between the skull and dura mater. It kind of helps out if you kind of scroll to slide number 22 for a minute, and you can kind of follow along as I'm describing it. So you have between the epidural and with epidural hematomas is kind of above the dura mater, okay? So above the dura mater, epidural. Subdural hematomas is below the dura mater and between the arachnoid space. So you can have bleeding outside the brain and then inside the brain. This is very significant. We can, if you go back to number 21 for a minute, slide number 21, talk about blunt trauma, which is the most common cause of epidural hematomas. You see the hammer to the side of the head. I'll talk more about the significance in a minute about that. Subdural hematomas is something that's below the skull, kind of inside, and it makes a big difference as how we kind of treat it. Most of the time, these can be caused by head trauma, as you know. So moving on to slide number 24, epidural hematoma. What do you see a part of that name? What I see is epi. What I think is epinephrine. Epinephrine is very fast. It goes through our bloodstream. It's very fast, raises everything. Someone can have an epidural hematoma. It's usually related to trauma associated with a loss of consciousness. That's what LOC will stand for on your, I believe, on your PowerPoint presentation. So people that have epidural hematomas, they will have a significant loss of consciousness, and it kind of stinks us because they deteriorate really rapidly. What we can see is, say, for example, people get hit in the side of the head, right on your temporal arteries. You know how when I was a kid, my mom would always worry about, don't get hit in the head, don't get hit in the head, on the side of the head, by your temples. You gotta watch it, you gotta watch it. She was right, believe it or not, because you have these temporal arteries. It's very high pressure, feeds a lot of blood to your body. If you get hit in the side of the head there, you're most likely to have an epidural hematoma. And it is very significant. It is a life-threatening emergency. Usually what happens, say for example someone got hit, I wasn't wearing a helmet, I was playing softball, and I got hit in the head with a softball. I tell everyone, hey, I'm fine, it's alright, I'm doing fine, just a little bump on my head, nothing significant. Then as you start to watch me, I start to get more sleepy. Get a little bit confused, and then all of a sudden, boom, rapid decline is what happens with these people that have subdural hematomas. It is a medical emergency. No matter what, if you were hit in the head, strike your head, in a car accident, so forth, you need to get seen, because these people, this is how people die. Many celebrities have died because of having an epidural hematoma. It is very significant. So now the difference between epidural hematoma is a subdural hematoma. Now, it can basically be the same signs and conditions, but when you think of sub, you think of slow, sub. It's slowly developing. And so a subdural hematoma is something that is very slow in nature, and it kind of develops. So basically you get hit and it kind of ruptures a blood vessel, and then it slowly starts to build fluid. As that fluid builds, it pushes onto the brain and spinal cord, and someone can actually herniate where the brain and spinal cord are going through the foramen magnum. Now, that's pretty significant. And we do see patients that would complain of the worst headache of their life. They have the worst headache of life. They're having vision problems, double vision. The sensitivity to light is what we're seeing. With these patients, we can diagnose it via a CAT scan that they're having a subdural hematoma. Nonetheless, the treatment for both of these are pretty much the same. We got to look at how much blood is there. If it's epidural hematoma, see if the blood resolves. The body does a good job of reabsorbing a lot of the blood. Same thing with subdural hematomas, seeing if the body absorbs some of it. We want to give medications to control the blood pressure. We want to keep the blood pressure high so that we maintain the perfusion that's needed for the brain. We never want to decrease someone's blood pressure. We never want to let someone's blood pressure go down even to an excess of 160s over 90s. We want to keep it above that. So we want to keep it high for a normal person like us, but we want to keep it high for them, so that we can keep that brain being perfused effectively. Another thing that we'll do is we can give drugs. If the brain has a lot of swelling, we can give drugs to kind of decrease a lot of that fluid. The only bad thing about that is the most controversial drug that we use is called mannitol. It's just like a sponge. If you take a sponge and you put in a box of, maybe a box of little Tupperware thing of water, what you'll see is that sponge will pick up all that water, but eventually after a couple hours that water keeps coming back out. So it goes away, then it comes back. And that's what happens with the drug called mannitol. And so that's kind of the medication treatments. Now the surgical treatments is what we would do. We would actually have a burr hole. Is what they would do is place someone, we call it a bolt. We can place a bolt which will try to drain a lot of the fluid off the blood. If they have a subdural hematoma or subarachnoid, we will try to drain all that blood off, and it actually works out pretty well. It looks creepy when you see someone that has someone coming out of their brain, but it actually works out really well. So moving on, I would talk about 27, cerebral concussion, then we're going to talk about cerebral contusion. Anytime you hear concussion, it's bruising. So concussion is something that's caused by the violent back and forth, usually a blunt object, and usually we refer to this coup, contra, coup, insult, where the brain sloshes forward and back and forward and back. Usually with these people, they have a loss of consciousness and they have amnesia up to 24 hours afterwards. The big thing with people that have concussions is that they have blurred vision, nausea, vomiting, and a headache is a big common thing. Cerebral contusion is more serious. Signs and symptoms usually last greater than 24 hours, and it involves the bruising of the tissues beneath the brain, and you can have some permanent damage. So if you look on slide number 30, you see the sloshing of the brain with the concussion, but the contusion is that sloshing of the brain too. However, you're now bruising. It's enough force to cause injury and bruising to each side. Okay, hopefully I explained that to you enough. I'm going to talk about the next thing is paraplegia and quadriplegia. Right now. Okay, so slide number 41, we'll talk about that real quick. So slide number 40, with epilepsy, it's pretty interesting. Someone that has epilepsy basically means a seizure disorder. There's a lot of different kinds of seizure disorders, just so that you know. So when someone has a seizure, think about it. You are doing a 5-mile race, but you only have 30 seconds to do it. And you're going to accomplish it in that 30 seconds. And so the brain is going so fast that at some period of time there's just a malfunction in there, and then all of a sudden someone has a seizure. Now there's different forms of seizures that we talk about. So if you kind of follow along on the next slide, I'm going to give you an overview. So we have petit mal seizures. Petite mal seizures are also known as absent seizures. We see these in younger adults and younger kids. What these petite mals or absent seizures are really interesting. If, for example, you're looking at someone and it's kind of like a deer in the headlights, you're like, "Are you there?" Someone says just staring off into space. That's actually an absent seizure or a petite mal seizure. Kids have this a lot, and it's hard to diagnose. How we do diagnose it is the teachers would say, "You know what? So and so was just kind of not being themselves in class, and they were staring, and they were confused afterwards." Well, they need to go see a neurologist, and they need to have some scans to kind of see what's going on. An EEG is how we would do it. Now, on the flip side, the most common thing when you think of seizures is a tonic-clonic seizure or grand mal. Tonic-clonic, someone is flashing, their arms shaking, moving around, going like crazy. So with tonic-clonic seizures, this is the most common thing that you see. So someone has a tonic-clonic seizures. Most of the times they do not last that long, I can tell you that. Usually it's about a period of 30 seconds, minute if max. But when someone does have a tonic-clonic seizure, what we will see is that people call 911. Then as soon as we get there, they will be in a stage called the postictal stage. The postictal stage is when people are trying to recover, where the body is recovering from that stage. Someone's postictal stage can be different than anyone else's. What we see with people that are in their postictal stage, they usually, for the most part, are really combative. They will bite. They will try to do everything they can because the brain is trying to reorganize itself. Now, I talked about postictal stage, but I forgot something else I just reminded myself of. When someone has these tonic-clonic seizures, something interesting, they would talk about an aura. And what an aura is what someone usually senses or what someone smells that is kind of like a trigger to let them know that they're going to have a seizure. So some people have told me they smell citrus, or they might taste citrus in their mouth. They may have orange juice, taste orange juice or so forth, and they know they're going to have a seizure. Slide number 43 talks about the treatment of someone that's having a seizure. People who are having seizures, we would worry about. I always would hear, "Oh my goodness, I tried to put the spoon in their mouth to make sure that they weren't choking." I seriously so many times wanted to rip some people's spoons out of their hands because I can't believe that they would try to put that in someone's mouth. First off, if someone is having a seizure, never, 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 never put anything into their mouth. If you're worried about them swallowing their tongue, I'll give you 1 second, about 20 seconds here. Try to swallow your tongue. I just tried it, and it didn't work. I tried to swallow my tongue, and it didn't work. So if it didn't work for you, I don't think it would work for anyone else that's having a seizure. Some people worry about them biting their tongue. That's the least of their concerns. If they bite their tongue, that's fine. We can put it back together. We can fix it. Don't put anything in their mouth. What you want to do is try to protect them from hurting themselves. So if they're banging their head on the floor, put your hand underneath and let their hand bang on your head just to pat it, or find something that could pat it. If they're flailing around and getting tangled in furniture, move everything away as best as possible. So when someone is having a seizure, try to move everything away. So I'm going to go on and see what else I had to talk about. Slide number 52, I was going to talk about real quick, because I had an interesting story to go along with that. So transient global amnesia. I talked about someone that was having a stroke. When I was working in Globe, Arizona, on the helicopter, go figure, transient global amnesia. I worked in Globe, Arizona. So I was there in Globe. We got a call for someone that was having a stroke. So it was a scene call, and the ambulance called us, and they wanted us to transport someone that was having a stroke. So we had this guy completely out of it, couldn't remember where he was at, couldn't remember his name, didn't know anything what was going on, and so we treated him like he was having a stroke. So we did that, and come to find out, we get to the hospital, and the doctor said he was never having a stroke at all. I was confused. He had the stroke-like symptoms. He was very confused. Something wasn't right. The doctor said he had transient global amnesia. It would be fine. It would be fine. He'll be good in about 6 hours. These people, believe it or not, have these. It's a weird phenomenon. They just had this weird lucid part for about a period of 1 to 6 hours where they don't remember anything. And so we found out about it because the guy had a history in his chart that he actually had transient global amnesia, and so it was pretty interesting to see when someone had it and to kind of see. It kind of freaks you out. You think of it as having a stroke. I'm going to go to number 66, and we'll kind of finish the rest of this PowerPoint off. Guillain-Barré syndrome is a really interesting thing. What Guillain-Barré is, Guillain-Barré or Guillain-Barré syndrome is you have this progressive muscle weakness and pain and tenderness, sometimes tingleness, that starts from the lower extremities all the way to the upper extremities. So it's a paralysis basically that goes all the way from below all the way up. Not from up to down, it's basically from below up. And so we have these people that have Guillain-Barré syndrome. They have weakness paralysis, and it usually goes over 24 to 72 hours. For the most part, we know it's autoimmune. We may give some antibiotics for this. We may treat it with some steroids and so forth, but for the most part, it is autoimmune. So that is, for the most part, the highlights of this. I still want you to go through every slide to make sure that you know most of the material and that it's going to be beneficial for you. With that being said, quiz number 3, now that you've stayed and watched the rest of the presentation, quiz number 3 is going to be a take-home exam. And so I'm going to be giving you a take-home exam on next week, week 9, quiz number 3, which would be a take-home exam. There's going to be 100 questions on that exam. 50 of those questions will be on your final, or a good majority of those questions will be on the final, and 50 of them were not. This quiz also is a take-home quiz, like I said. You get to drop your lowest quiz grade. There's a lot of questions in it, but if you do pretty well on this quiz, you should do pretty well on your final. This is your study guide for your final. So in week 9, when I give you quiz number 3, that will be your study guide as a take-home quiz to prepare yourself for the final. That being said, I hope you enjoyed kind of the presentation. Kind of wanted to move really fast and quickly. I don't have that much space on here for YouTube and so forth. So I hope you enjoyed the lecture. And if you have any questions between now and then, please feel free to contact me. Like I said earlier, group presentations, everyone must work together as a group. Please work together as a group. All of us are adults here. I do not need to get into any of the cat fights or anything. Please act responsibly and act as adults. Thanks again. Hopefully you are having a good day. As you can see, I'm at work, and I will talk to you later.